I've been here in Jersey now about 15 months, and I feel very privileged to be here. I know your time is very precious. We have got a new government in place, we've got a very, very heavy schedule, particularly in health. So I don't want any minutes of the evening to be wasted. So if you can be as engaging as possible and ask questions, open questions. This is a meeting about the future of community health. And we've got a brilliant opportunity ahead of us all to come together to make sure that islanders in Jersey have the very, very best community health service that is possible to have. So we've got a schedule, we've got an external speaker, and a few of our speakers are going to be online, but I'm not going to go on any longer. I'm going to introduce you to Lynn Cappy, who's the Communications Director at Switch Digital, and she works closely with us at the charity, Family Nursing. So, and Lynn is going to facilitate this evening. Over to you, Lynn.
Thanks, Rosemary. Again, time is precious, and it's fantastic to see so many of you in the audience with cameras on effect. Prior to the elections, we hosted a community health hustings, and we asked prospective election candidates to come and speak to us and talk to us about their views and the way that they felt about community health care, and that we recognised that we needed further discussion. So I just wanted to outline a few rules of engagement before we begin. We recognise that community health care is a very emotive topic. We'll remain respectful throughout the event. We're not here to criticise the way services are currently delivered, and we're not here to discuss or criticise specific individuals involved in the delivery or the development of community health care. We're also not here to talk about the hospital or the hospital building or the Jersey care model. We're here to have a brilliant discussion about the art of the possible, the best practice and the future of community health care. So feel free to ask questions. We have Elaine and Charlie at the back of the room with roaming mics, so if you have a question, please do put up your hand. I trust that's clear, so let's go. I'm going to ask the panel very briefly to introduce themselves, because I think that's better to hear from them than me. And I'm going to start with Becky.
So I'm Becky Sherrington. I'm a nurse by background. I trained over 30 years ago back in Salford. I've worked across the Channel Islands as well as across the UK. And my current post is Chief Inspector of Jersey Care Commission. So I am responsible for the organisation that regulates and inspects health and social care on the island.
So I'm Rosemary Finley. I'm a nurse by background, and I would say that if you cut me in half, that's what it would say. Passionate about patient care and passionate about outcomes for patients. So I think that's all you need to know. I'll pass you to Claire.
Hello, my name is Claire Stewart. I'm currently operational lead for hospital services and family nursing and home care. I'm a nurse with 26 years experience, 19 of which have been in the community, where we've successfully implemented and developed new community services which have improved patient outcomes and experience.
And let's go online.
Hello, good evening. I'm Anne Hendry. I'm a geriatrician from Scotland. I'm a senior associate with the International Foundation for Integrative Care, and I'm particularly passionate about integrative care and community health being at the heart of that. I spent many years visiting and working with islands in Scotland, and it's great to virtually connect with the island of Jersey.
Thanks, Anne. We're now going to go to James.
Good evening and greetings from County Cork on the south coast of Ireland at present. I'm a primary care physician, a clinical professor in the School of Medicine at the University of Central Lancashire, and I've been working in probably all sectors of the National Health Service in England over the 39-year career to date, and 31 of those have been in general practice. Also worked for the BBC for over 20 years, plus some government policy work, but I'll give a bit more of the credentials and why I'm here in the presentation.
And that is a very nice segue, and I think with no further ado, we'll go to the presentation. Thank you.
Thank you, Chair. I shall just start to hopefully quickly share screen. And okay, I think we're good to go. Please, Chair, tell me if otherwise. Added to some of the work I'm doing, one of the main focuses at the moment is a programme I'm running in England looking at a programme to reduce health inequalities, one of the big ticket issues I think we're going to be addressing as we are recovering from the pandemic. Are we going to show those on screen? I can see the screen in the audience, is that?
Just a wee technical issue.
Okay, the next slide now then, we may. Just to say who is this fella, I won't go through this, you've had the introduction, but it was just to, what I'm going to try and do is put into context and provide evidence of how important community-based services are the anchor for any health and care service development. Many health and care systems are looking at developing their services. Some are looking to transform services. I'm currently advising the government of the Isle of Man about transformational programs. Some are looking to improve current services. So on the left there was just some of my background. On the right, the experience whilst I've been a clinician in the NHS. My experience hopefully will be bringing into evidence from Europe, North Africa, North America, South Asia, where I'm still working in disaster medicine, Australia, some new work in the Middle East about primary care centre development, and some work I've done in China as well. So this is not going to be an English or NHS-centric presentation. What I'm going to present is in the context of some of that experience. So on to the next slide, please. And that is something that is to put into framework. If any health and care system is going to optimise its performance, if it's going to be high performing, there's a recognised framework now for developing health and care services. It's a framework that describes the optimising of an approach to performance. It was first described, an idea from 2006, from America. It was the Institute for Healthcare Improvement, an organisation based in Boston, Massachusetts, that first described a triple aim about, number one, any aim of reform of healthcare should enhance the person-centred care, focusing on the needs of the person rather than the needs of the service, and ensuring there's a shared decision process. Self-care is inherent in the delivery to the individual. So it's about enriching the experience, and any high-performing healthcare system should that have as number one. Improving population health, that is looking more at the cause of ill health and gaining a better understanding of the local need of a defined population. So that screening, early detection and prevention, which are often based in community services of diseases, becomes the defining principle of care provision. And the third, which I've jumped over, is that we always know that needs and demand in any system often outstrips the supply. So you've got to look at improving performance, improving productivity, and an American style, reducing per capita cost per care overall, rather than always looking for new investment, because that is always a difficult issue when services are outstripping the supply. The triple aim had been regularly refined, and in 2014 there was a couple of pieces of research or papers, one from America, one from England. Both claim that they could put the fourth one in, which is, we recognise the biggest financial risk to any health and care system is the morale of the staff. And I think that was an oversight in the AAA. So improving how both health and social, managerial professionals delivering the care have improved experience, we have better workforce planning and sensitive team development. And if we get that right, most systems I've seen who are looking at those 4 areas do have a high-performing health and care system. The next slide, just to again say, where we talk about the best health and care systems in the world, every 2 years a report is produced. It's looking at the 11 highest income countries in the 38 member countries of the Organisation for Economic Cooperation and Development, or better known as the OECD countries. And this is where the UK often prides itself on being the #1 in the world. I think you have to also, it's 5 domains. This piece of work is done every 2 years. It's a research piece called Mirror Mirror. It's the Commonwealth Fund, which is actually based in New York, and it's developed to compare the US system to other high-income countries. And the US regularly comes last of those 11, and they use this to reanalyse their health and care systems. The UK usually comes 1. But it's interesting when you're looking at what we've really achieved in the UK in terms of setting standards. NICE and CQC are not the envy, but recognised as great processes to improve the safety and quality of service. There's usually been good access, but that's falling good access that is free at the point of need, not based on anybody's ability to pay, which isn't inherent across systems. Efficiency. Look at the bottom line. If you want to get better from a healthcare system, it might be that we should be listening to Australia, Switzerland, Sweden, the Nordic countries. And if you go to the next slide, what's been happening, that was 2017 I just showed, over the last 4 years, largely because of access to care, which is faltering in the UK, it has fallen down the rankings. So it can't claim to be by what is recognised as possibly the best comparative research between healthcare systems. It can't really claim to be the best now, and we're seeing a change in that in Scandinavian countries. The worrying thing always, and that's why when I'm advising on the development of any health and care systems, particularly how to strengthen the community-based systems, we need to look across. There isn't a perfect health and care system in the world, and too often, local areas, certainly the Isle of Man where I'm looking at the moment, just adopts particularly NHS England's approach. And it's not always the best when you're looking at the outcomes of care. Not a criticism, it's an observation, it's a piece of research. The next slide, again, looks at some work that I've done. The K7 bit is the Kingsland 7. These are the areas that if you are going to transform care, not necessarily improve it, and you are going to look at extending care within a community setting, which often is, and the evidence shows, is the way to be most productive, the best utilisation of resources, and the best outcomes of care, then transforming often is a long, multi-year process, I say, of exhausting work, and no one gets it right first time. So you should always forgive yourself if things go wrong, because good transformation is often a sequential range of experiments, testing, sometimes resetting, but recognising that you can't have a linear approach to improvement or indeed transformation. I've already said about some of the issues that are important about improving the experience of care, but also the improvement of the morale of the staff doing it, I think is always the biggest financial risk. But there are 7 items and some of the qualifying statements with them that I would always suggest are the key principles, the key elements for not only success, but sustainability. Too often I see health and care systems on a cycle of events, sometimes a very short cycle of event, sometimes it's the political cycle of event every 5 years, to change the system or try and improve without recognising these key points. The next slide is sometimes health and care systems do scratch their heads about why, when well-meaning reforms are put into place, that they fail. Again, there's good evidence that whilst most importantly, when you're looking at reforming care, if it is a case of extending care in a community setting, then it's quite right always to start with the care delivery. And often care reforms over the first 2 to 3 years rightly look at new ways of delivering care, new care pathways. What happens though is that once you have changed patient flows, where patients are being cared for, then often you will have to change allocations, and the allocative value within a system needs to change. So payment reform must happen to follow that, and that is one of the issues that often fails. Because once payment reform happens, institutions have to fail. And don't have to fail, have to be supported, but have to change. So for example, as we've heard many times, some of the lower complex, lower cost type of work, particularly being done, say, in an outpatient department, could be done in the community. We look at reform pathways to deliver extended range of services. We look at trying to discharge patients earlier from hospital beds. We try and reduce readmission rates, etc. But that means that if you are successful in the long term, then payment has to follow where the patient goes. And if you are going to reform, for example, medical outpatients, where you're saying much of that work could be done in the community, you have to at some stage say, what happens to medical outpatients? That is the difficult conversation. If that doesn't happen at the start of the reform, then there's always this difficult issue about trying to maintain everything, because with care reform, often it is instead of, not as well as, if you are going to be consistent with the quadruple aim. I want to briefly just say one of the next slide, which is some work that I've been doing over a number of years, and this is now working partly in England. We have created primary care networks from some work I was doing in the 2014-2015, which was describing a model of extended community-based care, which could do a lot more screening, detection, prevention work, and help the management of patient care in the community setting. These are just some of the responses from different health and care professionals and people who are receiving care about this new way of working, and things that we're always saying that we're trying to do. We're trying to retain, defer retirement, retain clinicians, even getting them to return to practice, making people feel valued, engaged, and not least people who are saying we're getting a more responsive system, a more accessible system, a more equitable system, and a system that is working for me, particularly where I want care closer to home. The next slide, I'll come to the actual model if time allows, and Chairman, I'm keeping an eye on a watch, but I can't see into the room, and please do let me know if we need to curtail any time. I'll just run over these next slides, because when they were saying about what is the evidence behind extending service care in a community, there is a really strong evidence base. If you're going to reduce the burden on emergency services, for example, A&Es and waiting times, you need to invest in community services. We're already seeing the mistake being made, my words, but our new Secretary of State for Health in England, again, is looking at the burden on emergency service and A&E wait by focusing where the symptom is, not the underlying cause. And it's about the investment in extended community services, which this evidence. Time won't allow me, the small numbers on each of those lozenges gives the research that does prove it. Some going back to Barbara Starfield, who in the 1970s, working out of Johns Hopkins University, was looking at a lot of the evidence for primary care in its broadest sense. And when I say primary care, I mean that as a philosophy and a way of working, not the level in the system, and certainly not just general practice. General practice is just one part of a much wider service called primary care. The next slide is the evidence that is saying that whilst list-based practice is what is the basis of the NHS in England, as I understand in Jersey as well, where you access healthcare registration with a general practice, whilst I thoroughly enjoyed my 31 years in clinical practice in general practice, it was a model more, and this is the contentious issue, more for the 20th century. What we really need to do is still value the primary care physician, but within a multidisciplinary team, using the list-based practice to scale a service where we can look at population health need, not just a very small group of people, and extending the provision of care through whole-time equivalent developments in a team that can provide still the seamless care that people always expect from their registration, care that is community-based and closer to home. It provides early diagnostics, preventative care, as well as rehabilitation and the continuum of care in a community setting. But that can't be done in an individual general practice, I would suggest. But there are ways of scaling that, not destabilising everything we've got, but producing community-based services that really have an impact on the whole health and care system. The next slide, again, I won't labour this, but it does say that we've got very good evidence that if we get the team-based care right, we not only meet the quadruple aim, we get much better individual outcomes of care if you work in multi-professional teams, not the traditional teams or the silo teams we have, where we have the traditional general practice, sometimes with nursing support, then community services are sometimes disconnected, or that there isn't that one team approach. So a model of care in the community for scaling primary care services to deliver the quadruple aim, or something I call the primary care home. It's a set of principles, but it is trying to take that current state of the total population need to go and see the GP, now being that the needs of that local population and individuals is seen by the right person first time, and they have a finished episode of care within still the setting of what was traditionally general practice, including the GP. But we've seen that this is some work that has happened. They're now called primary care networks in England. They're still in the rudimentary stage of development, but it's recognising that you can start to deliver an extended range of services in a community base by this type of approach. It's an approach that I've seen now developing in North America, in both the US and in Canada. It's an approach I'm advising the Kingdom of Saudi Arabia about. It's some work I'm actively doing with the government in the Isle of Man, so it does work on an island community as well. I think, Chair, we're getting close to time, but this slide says it's not theory, it's evidence. Without a large investment from the concept in 2015, by 2017 we had a 12 million population served, and we were starting to see some of the benefits of not only better patient outcomes, but also reduction in emergency care, in A&E admissions, in hospital admissions as well. Some of the key indicators that most healthcare systems are looking into. The next two slides just, again, give the evidence behind the learning about how to mature this approach. Primary care home is just a working title. It's a set of principles, and this is just the evidence from the work we did in the UK about how to socialise it, engage the right people, take a different approach to prevention in terms of understanding the needs of the registered population, a slightly larger population than the average general practice, getting the care model right, the multi-professional team right, and what we're then finding that multi-professional approach in terms of education and training, in changing behaviours, and particularly what has always been the public's top concern in any health and care system, waiting and access. We were seeing significant impact by extending this type of work in a community setting. If we go over the next two slides, because I'm really conscious now, Chairman, that I've probably gone...
You've got 3 minutes left,
Quite.
you're absolutely fine.
Oh, right. Yes, I'm often told I can become very garrulous about these sort of things, where is it... So the next slide is, again, if it is principles into practice, we have, again, a strong evidence base of how this could work. And it does involve services that are way outside of general practice. It quite rapidly requires the integrated approach across community nursing, across mental health services, across rehabilitation services, that becomes not necessarily a new entity in the early stages, but a new single team approach, which has a well-tried and tested journey now. The next slide just says, whilst this sometimes sounds quite extensive, it is not destabilising what people have always recognised as first contact care by registering with the entity currently called general practice. I would suggest a primary care facility, a primary care centre, and that centre is looking at the needs of the whole needs of the registered population in terms of better management. Sometimes we just create services based on the perception of what is required as opposed to the actual, and it's amazing how different that can be. But the approach is building on the best of what we've developed in the UK. What I know is the same in Jersey over many years since the inception of the NHS. But it is taking it to a level which probably needs a better approach for the needs in populations of the 21st century. I think that takes it to the end, Chair. I wanted to leave time for questions if that was. I've just got the last slide of people who want to get in touch or follow. There's some the usual social media aspects, but hopefully that's given a whistle-stop tour on some of the evidence. I'm happy for those slides to be utilised and scrutinised and the evidence behind them. But it was to try and put into context of how communities-based services, as I was saying earlier, are the anchor for any health and care system development. And that's not a sector debate or a conflict with our important hospital services, but some of the issues that are challenging all health and care sectors about overuse of hospitals, long waits, poor access, are going to be served best by strengthening community-based services in a partnership with our hospital services, rather than always the investment in something that has probably been lost in the debate. I heard one colleague at the start even say something which I find quite pejorative: out of hospital care. I'll explain why, but we need to be talking about the strengthening of community-based services. Chairman, at that point I shall take a breath and happy to stay on if there's questions, or if questions come a bit later.
Absolutely. Oh my goodness. Thank you ever so much. There will be an opportunity for questions as we go through. Does anyone have any burning questions for James right now? Got microphones roving and roaming as we speak. Shy audience. Oh, no, we've got.
And thank you very much for a very informative talk, Mr. or Dr. Kingsland. I'm Mol Scott, Deputy of States Assembly. You mentioned scaling, and you obviously have got a background in the NHS, and you were presenting a model which I kind of had a bit of difficulty quite kind of understanding the vision when you were talking about GP practices and then having these multidisciplinary teams, and perhaps in terms of translating that to our own community, because we are a very small community. We've got 100,000 people in our population and have the similar kind of, the staffing issues that we've seen worldwide. So in terms of our small population, in terms of how you sort of move away from centralisation to care and community, what you really mean in terms of our particular community of 100,000.
Well, thank you, because I do have a couple of years' experience now working on another island economy. As I was saying, the Isle of Man. I've been an advisor to the Isle of Man government for the last 2 years, because they're looking at, and of course that's a population of 85,000. It's more than Jersey, but the same, I would suggest, not knowing the details of the pressure on workforce and workload in Jersey. They are still having the same issues that many health economies about recruitment, retention, and building a service that isn't largely dependent on hospitals, particularly where the traditional hospital, certainly the NH hospital, doesn't really work or perform optimally in populations less than 250,000. Other than it becoming very, very high per capita costs. What an island community could still benefit from is still, depending on the geography, what we've been doing on the Isle of Man, the affinity within certain parts of the community is scaling to a point where you can look at not having just visiting people, but bringing in whole-time equivalents to produce a multi-professional team that meets the holistic needs of a local population. We're talking on the Isle of Man groups of around 20,000 people. But for that sort of size, you can get a much better understanding of population health need and then how to manage that need, rather than very small groups. My own practice had less than 6,000 patients registered. What I think I did quite well was wait for people to get ill and then treat them, because that's what most systems do. You make an appointment with your general practice. What we didn't do with this space, this is the underlying principle of primary care home, is to do an analysis of the real need and then build a service against that need. And that sometimes isn't the same as responding to the requests of individuals, which I'd like to think I did quite well for 31 years. But it's very difficult to do the analytics on very small groups, population sizes much less than 20,000. It's hard to do that. And if you've got population size less than 20,000, it's hard to have whole-time equivalents. You have visiting people or parts of people doing bits, and what people like in their registration is the continuum, the consistency of carer, their trusted healers that are there for them in the long term, in the continuum, rather than just moments in time. Hopefully that's, so the experience of doing it on an island population, as opposed to the networking in England, what we're finding, it does work on an island population. It's still in its infancy on the Isle of Man, but it is a process that is being adopted in terms of principles rather than the background.
Thank you.
Does that help?
Thank you.